Tim Phillips, I'm sure everyone knows, is based at the Liphook Equine Hospital in Hampshire, where he's one of their senior surgeons, and there is no doubt really that within the UK, he's quite a long way ahead of all the others in terms of experience with Wobbler surgery. Tim.
Thank you, Cecilia, and thank you for the invitation to talk to you all today. Just to add to Celia's introduction, when she invited me to speak, let's be quite clear, she said three things to me. She said, you've only got 20 minutes, which is considerably less than everybody else. A lot of the audience won't be vets, which is why we've invited you to bring the simplicity to it. And what we want is the UK perspective. Well, I can do most of those things. What I possibly can't do is give the UK perspective in a way. I wouldn't presume to speak for the UK. Even Theresa May doesn't do that, so I can't see how I can. But what I can say is that the experience that we have at Liphook is at least, I think, the only experience that is generated by a UK team doing Wobbler surgery in the UK. And so there's nothing necessarily good about that, I might add. And even that is originally informed by tuition from America. When I first started doing them, I was still in Newmarket. It was done with surgeons, Alan Nixon, Jimmy Robertson coming over to Newmarket, helping me. And that's still the way it goes on in the UK quite a lot, probably sensibly. However, for rightly or wrongly, what we have done is to develop our own team, and over the years, 2 decades of it, amassed our own experience up to a point. It's still only, it's less than 100 surgical cases in the whole time we've done it, which is peanuts compared to American experience. And so you need to bear that in mind when I'm standing up here purporting to give the UK experience. Now, a lot of what I'm going to, or had scheduled to talk about, predictably enough, is going to be somewhat duplicate. So I'll try and sort of home in on some of the perspective issues, perhaps, that might differ or maybe haven't just been highlighted by Steve a bit there as we go along. So apologies if it's a bit interrupted and sort of multi-paced. First of all, I'm going to set a test. Don't want the answers now. We'll come back to this later on. There's 2 images there. We want to know later on what are those of, and there's a reason for that, which might become clear. Before we talk about Wobbler surgery, we need to know what it is we're treating, and the condition basically is cervical vertebral malformation and or malarticulation, which is basically malformation and malarticulation problems with the joints between adjacent or multiple bones within the neck. That's because the vertebral canal supports the spinal cord, which is somewhat neurologically important to life, and it's damage to that spinal cord. So the Wobbler syndrome, if for want of a better definition, is really cervical vertebral malformations that lead to compressions and damage to the neural tissue of the spinal cord. In other words, stenosis and compression. Now, it can happen in, simplistically, in 2 sorts of ways. One is an instability of adjacent joints, which leads to what we term a dynamic compression, and Steve demonstrated that much more ably and better pictorially than I am here. But basically, you get this movement, probably abnormal flexion, some people call it subluxation of 2 adjacent joints, and that creates pinch points between the roof of the spinal canal and the floor of it, and then causes potential damage to the spinal cord. You can see from these pictures, and this is true in radiography as well, which is one of the limitations, that it's simply 2-dimensional. It's important to remember that there are other ways that compression of the spinal cord can happen. And that is also by enlargement, abnormal enlargement of the tissues, both bony and soft in nature, that form the joints of the vertebral canal. And that leads to what we might sort of simplistically call the static compression. In other words, it's not posturally dependent. It is a feature of the of enlargements of the articular processes, and it can happen peripherally. It's circumference. The 3D of this is the spinal canal is a circumference, has a circumference, and any of the bony or soft tissues that make up that diameter, if you like, can enlarge and cause pinching of the spinal cord. Not necessarily just as at the top and bottom of it, which is what 2D photographs tend to suggest. So what is the aim of Wobbler surgery? It's to reverse those two processes, really. It is to reverse the instability, create stability, and to lead to tissue atrophy. And as Steve says, the mechanism by which that happens is that if you fuse and if you take out the movement between two adjacent joints, simply that stability secondarily leads to a reduction in the hypertrophied tissues and decompression. The difference between the two is that creating stability, reversing instability, is almost instantaneous, I suppose. Not the neural repair, but the actual surgical effect is almost instantaneous, whereas reducing tissue hypertrophy secondarily takes much longer. And that's one of the reasons why prognoses can differ depending on what you're trying to reverse. What is a suitable candidate for surgery? Well, certainly as far as we're concerned, the single most important factor in deciding whether it's technically feasible or sensible or advisable is the horse wobbling because of a compressive cervical spinal cord lesion? And also, can the site, or as it often is, sites, be confidently and accurately, well, they can always be confidently located, but that confidence and accuracy aren't always the same thing, of course. Because not all horses that wobble have CVM. It's a normal neurological process of the newborn. And for lots of other reasons, trauma or infective organisms, it doesn't necessarily follow that a horse that is wobbling has CVM, as it doesn't follow that a horse with CVM necessarily will wobble. And acute onset, obvious traumatic episodes, such as this weanling here, which had a, probably also was bashed by its mum and had a catastrophic sort of fracture, subluxation of its mid-neck vertebrae. You don't need myelography to tell you where the compressive site is. In that case, you can be certain. Actually, that particular case, which was a weanling, we couldn't quite work out what to do with that, and we left it. That happened about 3 years ago. It's now, just having gone through conservative treatment, neurologically normal, insofar as we ever know what neurological normality is. So the mainstay of diagnostic is contrast radiography. Generally speaking, the current gold standard is the myelography, which Steve has described, but it has got significant limitations. At least it does have in our hands. It needs a general anesthetic. I agree with Steve. Doesn't seem to be a problem. Very, very few of ours would have complications following myelography, and actually there's a positive advantage to it if you're going to go ahead and do surgery, in that we think it teaches horses how to recover post-anesthesia, which is a good thing post-surgery. It's positioned, a lot of compressions are position dependent. In other words, they will only show up in flexion or extension, and even under GA in plain radiography, that's not always that easy to reproduce. It's two-dimensional only, and as Steve has explained, there's lots of different formulae and criteria, so-called objectivity that we can produce with it, but they've changed with time, they develop, they vary, there's disagreement about them, and in our hands, even now, there is a considerable degree of faith and subjectivity applied to myelographic measurements. So you're still a little bit guessing. Some not so, more than others, as Steve said. When you get a compression like that towards the base of the neck, a virtual obliteration of the dorsal dicolumn, you can be fairly confident. But they're not always that simple. Steve talked about that. So what's in the future? Well, more than I know about, no doubt about that, and the MRI stuff is interesting. For us now, we have this CT unit that it still requires anesthesia, but we can put even big horses through this CT unit and get down to below C7. So we are now routinely recommending CT myelography as our diagnostic criteria, not plain myelography, really. It seems more than most people can cope with, although you could possibly justify it to do both. If we had the choice, we would rather do CT myelography. The system is the same thing. We have a separate GA unit. They can go onto the table. The table moves forwards and through. It's a quick acquisition time. It's much quicker than plain myelography because all you do is roll the table forwards and back. It takes about 20 seconds and you've got the whole film roll in front of you. So it's perfectly possible. And it has advantages. This is a case that we've not had it long. We haven't put probably only 4 or 5 through it so far, so it would be wrong to be too dogmatic about it. But this was a yearling that was referred to us, and this was at history, sudden onset, grade 2-3. Nothing seen that was anything like certain on plain radiography or any compressive sites identified by myelography, plain myelography, which had been done pre-referral. So we put this through the CT scanner, and there's a few things. There were actually several sites, even though plain X-rays and plain myelograms had been negative or highly equivocal. You can see on this transverse section that the difference between the intravertebral picture here, so the white is the contrast dye column sitting around the spinal column within the vertebrae, is quite thick. When we got to the intervertebral site, along the track, if you like, it narrowed down very significantly, which looked, to us at least, pretty convincingly compressive. And you get the 3D benefit. So again, as Steve has shown, we can see here that there was an osteochondral fragment, totally negative on plain X-ray. But in the picture above, associated with that osteochondral fragment, you can see that there is a significant lateral compression of the dye column associated with it. Now, what we don't have is measurements in the same way that plain myelography does to have kind of back you up on that. Sounds like they might be coming even if borrowed from MRI. We aren't doing MRI yet either. But nevertheless, the kind of overall 3D picture that you can reconstruct from CT in our hands is looking significantly promising in terms of the accuracy and confidence with which we can talk about compressive lesions. The surgical options. There's one surgical option that we haven't done. We were involved in the in vitro work, but it is all these surgical fixations derive from Cloud. They're human procedures. That's what they do in human necks. Actually, now in humans, they're using plates, not the fenestrated discs. And that has been tried in horses. It's been looked at in vitro. Apart from fracture reconstructions, I'm not sure that I know of anywhere that's using the lock-in compression plates routinely. We aren't, certainly. So we're still using this system, which simplistically is described there. Originally, it was a bone dowel. Basically, you approach the neck from the ventral aspect. And what you're looking to do is to cross the disc space between 2 adjacent vertebrae and stick something in there that'll hold it tight and preferably make it fuse together in the bone. It was modified by the great Mr. Bagby, who created this fenestrated stainless steel basket, which is here, which basically the process of drilling the defect, if you like, in the spinal, in the vertebrae, and implanting the basket with bone graft material that you harvest from the approach from the outside of the vertebrae in the first place. And more latterly, because a lot of these, well, I won't say a lot, although it probably was quite a lot in our hands, tended to have the tendency to back out, that nothing really was keeping them in other than the sort of compressive forces of the two bones. And there was a complication with them backing out, so quite often we would have to augment that with a ventral plate, just a plastic polypropylene plate screwed in, which adds to the complexity and adds to the number of things that can go wrong. That has been significantly reduced by the development of this curved cut or Seattle slew cylinder, which has a thread to it. And now the technique has slightly changed from being a sort of simple drill and plug to the process of using a core saw effectively to create this full-dimensional depth of hole, leaving an internal peg. You can still put the bone graft in, and because it's threaded, it screws in. You tap it first, and you screw it in, and its retention capability is much better. It isn't for the faint-hearted. I mean, we've done several of these now. The more you do, the less nervous you get. But they're still high-stress situations in our clinic. They are, and it's much, much better when you've got a team that know it's not a very portable surgery. I have done these at other clinics. Frankly, I don't like doing it very much because it's a proper teamwork approach. The anesthetic positioning with the neck dropped right down below creates its own problems and abuse from the anaesthetists. You have to get the horse absolutely aligned. You need a midline approach. You have to have intraoperative radiography process going on. That's got much quicker with the advent of digital stuff. And the process, like all these things, it gets easier the more you do. The surgical approach is a little bit hairy. You've got to go down past the trachea, move the windpipe across to one side. You've got to avoid the carotid artery, avoid the recurrent laryngeal nerve, protect them, then get back across to the midline of the neck, chisel off the ventral process if it's there. Then you've got to work out, you see, if you can see here, the joint space is curved, and it curves caudally on the ventral side. And where the landmark really is seeing the disc space on this here, but where you want the position of the cylinders to line up is several millimeters back alongside from that. You want it here. So you need this intraoperative constant radiographic support, really, in order to be as sure as you can that you're getting it in the right position. And the actual mechanics of doing it, these are big drills with a lot of torque. I mean, we used to use a Makita industrial drill, and they create a lot of torque. You almost need two people to operate the drill, and it really isn't for the faint-hearted. And then these days, using the kerf-cut cylinders, I say we use this the core saw and reamer to enlarge it, and then a tap, and then basically just screw in the implant with a special tool, and that's how it looks when it's eventually gone into the vertebra. You can just see the one outer rim of the cylinder there sitting adjacent to the vertebra. And what you hope to end up with is something approaching this, although this is far from perfect. It should really have been a little bit that way to make it symmetrical. It's probably good enough, but it's rarely perfect. Not in my hands, it ain't. And then you've got the problem, the problem with all surgery is having to wake them up and get them back on their feet again. Horses, they don't help you sometimes. And there's a debate as to whether you should assist them or not. A lot of horses these days are assisted with both tail ropes and ropes on the head. We don't use neck ropes now because of this sort of, it just feels wrong to be hoiking a horse's neck when you operated on it and stuck a piece of metal in that you would rather stay there. So we do use a tail rope. Actually, these days our incidence of peri-anesthetic problems is much, much lower. Whether that we just got better at it or what, I don't know. But there was a time, certainly when we started doing that, a lot of our failure rate was based with not necessarily horses dying, but the forces of recovery creating that implant failure or something. So what is the success rate? Well, the truth of it is, I think, I feel a bit of a fraud giving a success rate because we only really work off those who've got much better numbers than us, and that's what we do. And even then, I'm not sure the numbers are that great. And comparisons are difficult. Are you comparing age against age? Are you comparing statics against dynamics? Are you comparing single site against multiple site? What is the comparisons? And to me, it's very, very difficult. I generally give people some optimism that we can make the horse better clinically, possibly, quite often, not better enough, but it might be. And that sounds like 50-50, which is what I think it is. It's certainly in our hands. We have some some limitations and some factors that either increase or decrease that prognosis. For instance, you know, Steve, a lot of our horses aren't thoroughbred, probably half and half. We see at least as many warm bloods in our practice as thoroughbreds, even as wobblers. The bigger the horse and the further down the neck you have to go, the more difficult it is, I think, to be confident and predict decent success. Actually, if we get a nice yearling with a 3-4 dynamic instability, we're pretty optimistic about that these days, but we don't see very many of them, really. That's the trouble. So should we be doing wobbler surgery or not? I mean, it's a debate. It probably rages more in the UK ethically than perhaps it does in America. I don't know, but should we be doing it? The fact that not many people are doing it is A, a reflection of the numbers, and B, I guess that just testimony to the fact that there is almost an ethical debate out there. Well, why shouldn't we? Because it's usually, or at least often, not a complete recovery. And an improvement of some degree is good, but it's not necessarily good enough. The complication rate is relatively high, as against other surgeries. I mean, not necessarily as against other clinics, although probably that too. But you know, things can go wrong, and I think it probably is. It's certainly a higher complication rate than arthroscopy surgeries for whatever. Are there welfare aspects? I mean, is it reasonable to be operating on neurological horses, putting them through a big surgery and a long post-operative care time when actually making them definitely better is not a guarantee? Is it fair? Are there safety issues? People, generally speaking, are going to ride these horses again, or that's the aim. Are we totally happy to say those horses, once they've been through neurological reparative surgery, are safe from the human injury point of view? And is it heritable? A lot of people will say, I'm not going to breed from that wobbler because I don't want to breed another. So those are the pivot points of debate as to why not. But you know, sometimes it's really successful, and not just in young thoroughbreds. We have dressage horses out there competing at high level that have got baskets in their necks. Not many, but it does happen. You know, what's the alternative? Euthanasia. The survival rate after euthanasia is not very high. It's not unheard of for it to go wrong, but generally speaking, they don't do very well. So the chances of a wobbler horse getting better without surgery, give or take, you know, there's a few debates around foals and so on and so forth, and we do a few foals. Sometimes, of course, you get into that debate, well, it's now or never, and actually foals, I think, do really well. That's the problem, but of course they might have done well without it. Post-operative recovery these days, I think, is good. It's not a desperately concerning surgery to see the products of once you're done. Any horse is unsafe. Doesn't matter whether it's wobbly or not. You know, how much more unsafe is a horse that's been through wobbler surgery than any other horse you're going to jump? And I'm not at all convinced, and I'm glad to hear that I still don't have to be convinced, that there's any more of a heritability factor, genetic factor in wobbler horses than there is in horses with any other inherent condition. Take trauma and infection out of it. Intrinsic conditions, everything's genetic to some extent. There's no knowledge to there's no certainty to my knowledge that it's any more heritable in wobblers than it is in many others. So if we don't do wobbler surgery on that basis, then we don't do it on a whole lot else. So where might we do it? Well, the best candidates won't be the severest affected. Dynamic compressions, I think, offer a better. They certainly offer a quicker response, and that's important in the flat thoroughbred racing sphere for sure, because generally speaking, you're going to lose very many months, up to a year post-operatively with these anyway. One site is better than any others. 2 we will go up to. I have personally virtually abandoned doing more than 2 sites. Not because you can't get them neurologically functional, you can, but to me, a horse with three implants has such a stiff neck after it. Forget the neurology. It's just biomechanically compromised because it's got a stiff neck. And a mobile neck is an important part of the athletic function. take neurology out of it. So I don't like doing more than 2. I don't like doing 2 very much, and I just about tolerate doing 1. Recent onset, I think, is better, although some of the evidence questions that. It's much better if the expectations for the horse aren't that great. You know, running in straight lines is the easiest thing to do. Once you go beyond that, bends and put jumps in the way, I get more nervous about it, and the cell becomes less hardcore. That's for certain sure. And, you know, it is a punt. All surgery is a punt. There's a degree of punt about wobbler surgery that perhaps isn't present in others. And it's nice to have owners with you on the same page that that's where you're heading in, because what you definitely can't do is guarantee an outcome. Back to the test. I don't know whether anybody's remembered the answers to this. I'll give you them. I thought a stone's throw from the high street in Newmarket, we might get a better answer rate than that. Thoroughbred racehorse, you know now that that's a Bagby basket. So what? Well, the question is, what happens if you put those 2 things together? You get a thoroughbred racehorse called Bagby Boy. Bagby Boy wasn't the first horse in the UK ever to have wobbler surgery, because I'd done them before we did him. He was the first horse in the UK, I think, to be done by a UK team. We had to buy him to do it, fair enough. He was bred by a client of ours, and you know, way back in the early 90s. I think he was 3 years old when we did it, because that was his form. You know, he ran 6 times on the flat, 3 times before surgery. He came 17th out of 17, 9th out of 11th, and 11th out of 11. And then we worked out, when he was brought to us, we worked out he was wobbling, probably grade 2. So we said, I'll tell you what, we've got this new surgery, we'd like to do this to you. And they said, well, we're not paying that, you know. So we said, well, we'll give him to us, we'll do it. So we did it, and he did okay. We put him back into training. And at the 3 races after surgery, he came 10th out of 10th, 6th out of 7th, and 14th out of 15th, which just goes to show you can return horses to their pre-surgical level. What do you need to succeed? You need to be optimistic. Don't look back. The only thing backwards is regrets and failures. The forward-looking aspect is much more favourable, and you need a bit of luck. Thank you.